All right, so hi, I'm Hinal. I am ViTAL's Director of Operations. It's great to see everyone here tonight. And thank you all for taking some time out of your schedule to join us. I know it's like the middle of the summer, but this is an important topic and I'm really glad a lot of people are here to kind of discuss it. So for a quick intro on who ViTAL is, we are Northeastern's Healthcare Innovation Club. And our core mission is to basically help students develop connections, knowledge, and skills outside of the traditional classroom environment. And we work to provide insight into the different paths available in the healthcare field. And we basically hope to inspire students to pursue their interests in the field of healthcare and help them see that it doesn't have to be linear. So in pursuit of that, tonight we have Dr. Richard Wamai, Dr. Kayoll Gyan, and Dr. Maniar joining us to discuss and answer some questions on healthcare disparities. So we've prepared some questions and we'll be taking the first portion of tonight's evening event to ask them these, and they span from questions about health disparities to how we as regular people may be able to help with them. And in the second portion of the event, we're going to be opening up the discussion to all of you, so our audience. And if you have any questions, you'll be welcome to ask them. You can do this through submitting questions in the chat room, and you'll also be able to do that throughout the event. So if at any point you have any questions, you're welcome to submit them, or specifically at the end, if you have anything, you can do that then as well. Also during the specific Q&A portion, there's a functionality in Zoom that allows you to raise your hand. It's under the participants button if you aren't able to find it. If you would like to ask a question, I would ask that you turn on your camera just so we know who's talking and it kind of pops up in our cameras. And if you raise your hand, then I'll know who to call on because it's kind of difficult to judge it otherwise. If you're not comfortable turning on your camera, that's totally fine as well. We just ask that if you can, it'd be great to see people, but we understand that with Wi-Fi, it'll cause some lags and we don't want to cause any computers to like explode because I know that can happen with Zoom. And we also ask that if you're not talking to keep your mic muted. Aside from the speakers, you guys are welcome to have them on at all times. We just want to make sure that we minimize the noise that's coming through and that everyone can hear our speakers and their answers to these questions. And yeah, if no one has any questions, we'll begin. And I'm gonna first ask our speakers to briefly introduce themselves, what their areas of expertise are, and their work relating to healthcare disparities. So Dr. Wamai, would you like starting us off?
Yes, I can. Thank you so much, Inal, and good evening and morning, afternoon, where you are. I'm in Boston, and so actually a good time, I think. It's not too bad here. My name is Richard Wamai. I'm a professor of global health. I'm in the Department of Culture, Societies, and Global Studies at the university, and also I'm a member of the Africana Studies program, and many other, initiatives and institutes across campus, including the Initiative for Global Health.
Great, thank you. Dr. Gyan, would you be able to provide a little bit of an introduction for you?
Hi, everyone. My name is Kayoll Gyan. I am an assistant professor at the School of Nursing in the Vevey College of Health Sciences. And my work focuses on cervical cancer prevention among African-American women.
Thank you. And Dr. Maniar?
Hi, good evening, everyone. My name is Maniar. I'm a professor of public health practice in the Department of Health Sciences, and I'm also the director of the Master of Public Health program.
Great, thank you to all of you for joining us tonight. I'm actually going to start out with asking a few questions, just dive right in. So Dr. Maniar, could you start us off with how you would define health disparities in America?
Absolutely. So, I think one of the key distinctions, as we think about differences in health outcomes versus disparities in health outcomes. And, so differences in health outcomes. So if you have different rates of, say, cancer or diabetes or other conditions between two different populations, some of those may be due to biological differences, they may be due to other differences that are not necessarily preventable. So you may just, as a function of that, have different rates of disease in different populations. However, what we know is that there are differences in rates of cancer, rates of chronic disease, rates across other outcomes that are preventable, that are due to either access to care, that are due to the quality of care received within the healthcare system, or that are due to the quality of services and the extent to which services are available outside of the healthcare system. And I think that's really what defines a disparity, is when you look at these differences in outcomes that are preventable, where we should not have those differences because the factors leading to those differential outcomes across different populations, those factors are the ones that the factors are addressable, they're preventable, and they're leading to worse outcomes in different populations.
Thank you. And Dr. Wamai, Dr. Gyan, do you have anything to add for that?
Dr. Gyan?
I think he did a great job summing up the differences between differences versus disparities. And I guess I often rely on the World Health Organization's definition for health disparities. So I'll state it here. It's differences in health outcomes that are closely linked with social, economic, environmental disadvantages, which are often driven by social conditions in which individuals live, learn, work, play, and I like to add in age as well, because elderly are often a vulnerable population for many health disparities that are often overlooked as well.
Definitely. Thank you very much for that. I'm sure that provides a great overview for everyone.
Yeah, I could just add, maybe just to, I can take a metric, for example. I like health measurements a lot, and just to reiterate what Dr. Maniar and Dr. Gyan have mentioned already. So generally, health disparities are avoidable, they are unnecessary, and they are unfair. So those three elements define health disparities. The one other thing I could say is that if you were to look at the performance of health systems, if you take one metric of how well a health system performs, it would be life expectancy or longevity. Okay, so if we take that and we take population, Dr. John, could you mute your microphone? I think it's echoing back. Yeah, thank you. Yes. So, yeah, I mean, if we take the populations in the US and take the Office of Budget and Management or Census statistics and look at how the population is enumerated in the US, then you have these 6 basic ratio groups. And then you take life expectancy in each of these groups. The difference in these groups is about 35 years. And that makes the US have the highest life expectancy difference across population. It's not just a simple population difference, but it has other factors, such as socioeconomics, as already Dr. Jan has mentioned. But you could take that metric and say, wow, 35-year life expectancy gap difference in US populations, that's huge. And there is no country in the world that has such a high life expectancy gap between its population. This would be the highest in the world.
Definitely a stark metric that you pointed out. So continuing on your discussion point, Dr. Wamai, what would you say are the major misconceptions about health disparities in America?
Well, that's a good question. I think that, first of all, when we talk about, let's say, the definition that Dr. Jan has given us, or the analysis that Dr. Maniar has given us, I think it's that many people may not be aware, particularly like that statistic I just gave, 35-year difference in life expectancy. Who knows that? Who knows that that's the degree of variation in life expectancy in the population? So I think there is unawareness of these variations in population health metrics in the US. I think with the recent events that we are seeing, it becomes more and more widely known by large numbers of Americans. But you bet, among populations in the African American community in the US, many who are acutely aware of these differences. And then you have obviously people in the policy arena who are aware of these differences that have existed, but little action to address them I think, has been seen over the years. You could take individual diseases, whether it's HIV, whether it's cancer, and so on and so forth. So wide awareness of these differences, I think, is only perhaps becoming more, more evident among general population in the U.S., especially because of the recent events that we have been seeing.
Definitely. What are other speakers like to add to that?
Dr. Gyan, would you like to go?
Sure. I think I would add to what Dr. Wamai said is that one stereotype is that health disparities is caused solely by race or by an individual's decision. I think that, we hear these statistics so often that Black and Hispanic people have higher rates of dying from, you can just fill in the blank, right? For a lot of cancers, chronic illnesses and diseases. However, I think by taking that perspective, by saying that, it's based on someone's poor choice, it's kind of puts the burden for good health on that individual and kind of eliminates or ignores the societal factors or the contextual factors that people live, work, and play, going back to the definition of health disparities. And I think by doing that also, it kind of takes away the responsibility of these greater systems in which we live in and operate in from actually making meaningful policies and changes to affect the societal factors that creates these differences between health outcomes among Black people and other racial and ethnic minorities as well. And I think also for race being considered, the primary reason as to why one particular race or ethnic group has a higher mortality or incidence rates for cancer, for example, compared to another. I think also it's important to realize that race is a social construct, right? And that going back and looking at how race was constructed, it's important to realize that it was created as a way to categorize people, based on, right now it's more predominantly based on their phenotypical differences, right? But it was a way to characterize people and then also to link certain stereotypes or misconceptions to that race, and also in a way to use that as a way to justify the reasons why there are inequities within society, but it's not race that is the reason behind all of that. It's racism, right? And I think by just saying these different, when you say these statistics and just say, oh, Black and Hispanic people are more likely to die from cervical cancer compared to white people or white women, it kind of takes away the historical context of what has happened before we see these statistics today. And a lot of what we are seeing today is a result of history, of slavery in America, of the Jim Crow laws, of segregation. A lot of that is the reason why now we see so many different health disparities. So I think that's one of the major misconceptions, is just saying race or poor choices, is that it kind of eliminates, one, the responsibility on those that are in government or within these systems that can actually make changes to actually prevent these disparities. And the other is that it takes away from the historical events and kind of put these disparities just within a bubble when we don't exist in a bubble.
So I'll just add one or 2 points and then 2 very quick anecdotes. So I couldn't agree more, because I tend to think that health disparities are really the tip of the iceberg. The health disparities are the product of a range of inequities across so many different domains, and that when we think about the root cause that we have to address, it is systemic racism. It is the way in which racism operates through so many different structures. It's the way in which exposure to racism, that ubiquitous exposure to racism, actually impacts the biology of individuals in a way that we see differential outcomes. So it permeates so many different facets of life. And I think that if we really want to have a meaningful approach to address disparities, we have to be willing to engage in meaningful and honest conversations about the way in which racism operates across different levels and different institutions within our society. And so I'll share a quick anecdote. So years ago, when I was at Brigham and Women's Hospital, I was their first director of health equity programs, and really tasked with developing initiatives to address disparities across a range of different outcomes. So we had started with infant mortality as one of the key outcomes. So we were trying to get a better sense of the way in which different social determinants of health were operating in neighborhoods. So we did a quick analysis. We looked at 2 different locations of Stop and Shop. So one was in Brookline Village in Brookline, Massachusetts, with a pretty well-to-do, a pretty wealthy suburb of Boston. And the other one was in Grove Hall in Dorchester. You walk into the Stop and Shop in Brookline Village, and you are surrounded by fresh fruits and fresh vegetables and like these power bars and kind of healthy stuff. Although some may argue about the relative value of power bars. But when we walked into the Stop and Shop in Grove Hall, the first thing that we saw was a pyramid of these small drinks. They were called minis. These are not high sugar drinks, they're all sugar. There's only, the only 2 ingredients are sugar and water, and there's a higher concentration of sugar than water in these drinks. So it was these minis, and there was something 40 for $1 or something like that. And they had all of these sort of food products that were high quantity and low quality. So what is the responsibility? This is a major grocery chain that has 2 different locations set up very differently. I saw the same thing in Baltimore when we were being in East Baltimore, looking at 2 different locations of a major national pharmacy chain, where in East Baltimore, the section of the chain that sold alcohol was bigger than the section of the store that sold any other product. That same pharmacy chain in the area of Baltimore, where you have a lot of faculty and other folks from Johns Hopkins living, they had no alcohol being sold. So what is the responsibility of that corporate entity in terms of what is their role in perpetuating the disparities, and not just perpetuating, but really fueling the disparities that we see? And I think that's, I think when we think about health disparities, really having a broad definition of health. So it's not just physical, mental, and emotional health, it's economic health, intellectual health, social health, environmental health, and how they all come together.
Thank you very much for those anecdotes, and to our other speakers as well for providing such a great overview on kind of health disparities and misconceptions in general, because I'm sure a lot of us sometimes don't really realize what's going on and how much it's actually impacting how we view others. So to continue our conversation, Dr. Gyan, would you mind kind of discussing how you've seen health disparities in the communities that you've worked in and done research in? Because for all of those that are tuning in that didn't know this, Dr. Gyan is a registered nurse, and she provides the clinical perspective for our conversation today.
Right. Sorry, I keep forgetting I'm on mute. So I think that, right now I'm living in Boston, but I grew up in Brooklyn, New York, and which isn't much different than, the city of Boston here, where we see a lot of gentrification going on, or different, well, I'll take education as a social determinant of health and how that affects people's health outcomes. So when you think of education, you think of, there's a stark difference between the school systems that are located in inner cities versus those that are located in suburbs. And one of the main reasons for that is the difference in funding, where public schools are funded based on property tax, There are low property tax in low-income communities versus in the suburbs. But we know that education is an important social determinant of a person's health once they become an adult, and that's for many different health conditions, for cancer, for diabetes, obesity, at that. And so that was the kind of the main thing that stood out to me in my career, is just how important it is that the education that people receive, that is an indicator for what their health will be as they become an adult. So for example, when you have education, higher education, you're either able to have higher income, better jobs, that provide higher incomes. And with higher incomes, you have more opportunities, you have better health insurance, you have benefits, a way to kind of begin to build wealth. But a lot of here in Boston, looking at their education systems in predominantly Black and low-income areas of Boston, you see that Black and Hispanic students are less likely to graduate compared to white students. And you think of that in a place such as Boston, where, within 6 miles we have the best, the best universities in the country, where people are coming all over the world to study here. But what does it mean for the people that actually live here, right? And actually have to grow up within these areas, knowing that, they're surrounded by so much wealth and so much opportunity for some, but not for them. And I think that is the biggest thing that stood out to me as a healthcare provider and a person who grew up in these neighborhoods. For me, I grew up in Bronzeville, Brooklyn, and then later East Flatbush. So both of those are very similar in terms of Roxbury, Massachusetts, or Dorchester. So that kind of stood out to me as a healthcare provider, in realizing that, a lot of the opportunities that are provided to some are not provided to others, just because of the place that they live. And how can we go about changing that, or improving the health, or bringing the quality healthcare to these particular neighborhoods that need it the most.
And if our other speakers would like to add to that as well.
Well, I think, it's a very big topic, and I think it's really nice to hear these anecdotes, these experiences by both Dr. Maniar and Dr. Gyan. I am not haven't practiced any clinical work at all, but understanding health disparities is a big topic of my interest. I've done some work on HIV, particularly here in the US. In fact, my very first research project on HIV was in Baltimore in 2001, as I was starting at my PhD at Hopkins at that time. And we know the story of HIV to where we are today. Now we are starting a new story with COVID-19 pandemic. And the disparities we are seeing are clearly well spelled out, across the population distribution, whether it's here in the US or in the UK. The studies produce the same results, which is that African Americans at high increased risk of exposure to the pandemic, as well as mortality outcomes. The background behind that, I think, is like an upstream type of a phenomenon where you look at the outcome, which is these disparity outcomes, whether it's burden of disease, mortality, or whatever, and then you go downstream to find out what was the cause. What was the cause, for example, for low income status? What was the cause for lower levels of education or high obesity, and so on and so forth? So I think going just down that line, and then even studies that look at, if you control for all socioeconomic indicators, everything, education, income, housing, all of those, the results still show a gap in whether it's in life expectancy or other type of health measurements. So what is left behind is these aspects of this element of racism. And that is the only one that can then explain continuous disparity. When you control for everything else, the racism still remains as a historically entrenched injustice in this country over 400 years. How do we address that? That's obviously the elephant in the room, but I think in the recent events, we are starting to become more aware. More people are begin to become more aware, and I think it will require generational shift, but it is not enough. I think it's really great that we have seen a lot of structural changes, institutions, renaming of institutions, removal of statues, and so on and so forth, as a way to begin to address these inequalities. But it will take time. It will take generations to have really positive results.
And I just to build on both Dr. Wamai and Dr. Jan's points. A colleague of mine several years ago used to say that, if we had an elixir that could virtually ensure good health for everyone, wouldn't we invest everything that we have in it? My answer was yeah, right? Like, if you could, and not just good physical health, right? Kind of good health across all of the domains. So we do have that elixir in a way, and that elixir is education. And so when we think about disparities and thinking about the equitable, or in our current reality, the inequitable distribution of resources, and how the inequitable distribution of resources at a very early point in a person's life puts them at a disadvantage. And then when you carry that forward across all of these different inflection points in a person's trajectory, in a person's development, those kind of disparities either become amplified, or you're constantly trying to knock down barriers to address those different disparities. So when we think about education, oftentimes when we think about education and the relationship, or the importance of education, folks will talk about, well, if you have a good education, you're going to get a better job. And if you have a better job, you're going to have better outcomes. But there are other aspects to it too. So there's the piece around education as being fundamental to being able to acquire health-related knowledge, and to have a level of health literacy that can enable an individual to navigate pretty complex health systems. And our health systems are incredibly complex, right? So I've spent much of my career in sort of the public health and healthcare field. My wife, my sister, my brother-in-law are all physicians. When we had to help my dad navigate the healthcare system for a really complex issue, we were stumped. We had a hard time, between the four of us, with all of our knowledge and expertise, navigating the healthcare system to help someone. And that really made me realize how unnecessarily complex the systems are, and how important it is for us, if we want to talk about addressing disparities, again, really thinking about the way in which these systems were set up, and how can we kind of rethink the systems so that we're able to make access to those systems more equitable. I think the other piece when we think about education is around social standing, social support, all of those things that can play, and importantly, social capital, and how all of that has a big impact on health as well. Social capital, so when we talk about individual self-agency, the ability for an individual to advocate for themselves, right, to have that locus of control at an individual level, social capital is that locus of control at a community level. So in order for communities to be able to advocate for themselves, in order for communities to develop the political capital necessary to be able to prevent some of these disparities or address the disparities, so we need social capital first. So what do we need to do to help build that? And I think all of that ties back to education. And it's not that we start thinking of it when students are in 12th grade and we say, oh, we need to make sure they don't drop out. It's way earlier. How do we kind of create an entire system that enables students to succeed, that gives them the supports that they need, but also that creates expectations, and importantly, creates that sense of possibility for individuals. And I think that's the other challenge, and all of this ties back to not what individuals are doing, but the way in which structures are set up, and how important it is for us to really dismantle those structures and rethink them, because the structures themselves are embodiments of historical racism. And so unless we really address that, and we're starting to see that now, what we're seeing in this moment of time, when you have, all these corporations saying they're going to start to donate, millions, if not hundreds of millions of dollars to support Black businesses, to support Black nonprofits, to support these issues that we've been talking about for a long time. I think that's a real turning point, but it means that we have to elevate that conversation to, continue to focus on those root causes and sort of the real causes of the disparities that we're seeing.
May I add to that, and a point that Dr. Gyan mentioned earlier in thinking about the health disparities as defined by the WHO, in reference to a report that has that definition, 2008 report of the WHO called the Social Determinants of Health. Then Dr. Chan, who was the Secretary General of the WHO, said that in her remarks that health disparities cause death, are killing people. In other words, health disparities are killing people. Absolutely right, yeah. But you can go way beyond that, which is a point that Dr. Maniar has mentioned, which is, well, I mean, yeah, health disparities, but how do they result? So, as a Professor Vicente Navarro at Hopkins, who's a political scientist, mentioned in reference to that statement by the WHO, is that, well, it's not the health disparities that kill people. It's those people, those systems behind the health disparities that ultimately cause these deaths. And what are those systems? Which are those institutions that are behind them? So, it's a hard and difficult journey to begin to dismantle these embedded infrastructures that have been built over hundreds of years, in this country. There are studies from the UK that show Africans in the UK or Blacks in the UK have fairly similar access to health services. Well, because they have the national health system. They have a national NHS system that guarantees access and equal access to everybody. But we don't have anything like that here if we're just specifically thinking about health. So, but how do we create those systems so that we can have one single universal healthcare system that, to which everybody will have a right to, So we don't have a status in this country where our health is a right to everybody. It's not in the Constitution, it's not in government policies. And so, we have built this system over hundreds of years of exclusion of large numbers of people in this country.
Thank you, because that question was very important. I think the answers you gave provided a very in-depth description of kind of like what we're dealing with. And kind of going off of that, I know you guys mentioned education and just like the general elephant in the room, like how do we go about solving it? So Dr. Wamai, would you mind starting us off with what solutions have been proposed to try to remedy these health disparities on the basis of race? And what kind of evidence supports the implementation of some interventions versus some others? Just from like what you've heard of, what you've actively seen being done, or what you kind of hope to see being done?
Mm-hmm. Well, the US has a very long history of programs to try to address, health disparities. You can go way back to the war on poverty. I don't remember which president started this war on poverty, and then we had the war on cancer in Nixon's war on cancer. But you can go all the way back to W.E.B. Du Bois' time and the formation of the Office of Minority Health in the NIH and so on and so forth, and specific programs that are put into place to begin to address health disparities. In the most recent time, since about 1986, after the WHO conference in 1987 in Almaty, Kazakhstan, which was called World Health for All, by the year 2000, even here, DHHS started a program called Healthy People 2010, and now it's Healthy People 2020, and it'll probably be moved on. So in terms of policy level, I guess either declarations or sort of at the federal level, there are institutions, including in the NHS, or rather DHHS and the NIH, And of course, you have specific states that may have started certain programs. And then in the recent time, during President Obama's time, he started the Affordable Healthcare Act. So all of those are programs to try to begin to reduce health disparities. If you look at the American Cancer Society, they also had a strategy to address two specific goals. And so you have had these programs, and Healthy People 2020 now probably could be taken as the national program to try to address health disparities. You have specific disease strategies like HIV. There was that strategy that was launched by Obama in 2010 has also tried to address health disparities. So a long history, including, in fact, even trying to narrow that life expectancy gap over the years. The gap hasn't moved very much. I mean, you still have almost similar level of life expectancy gap across the whole 100 years of experience in the U.S. But there are, I guess, some small reports. I've seen one, for example, from Madison County, and where they try to, I think this is in Wisconsin, try to reduce this life expectancy, or rather infant mortality gap between blacks and white mothers, and they were able to do that over a period of about a decade in this specific county in Madison. It was a success story. It was widely reported around 2009, and how did they address this infant mortality gap? By decreasing extreme prematurity, that is extreme premature birth among Black mothers, as well as decreasing mortality for low birth weight, right? So that's a very specific target in a small area, focusing on one specific outcome. But and those would be, I think, sort of small reported interventions in specific areas, and I'm sure we could find cases like those that address and try to target some specific outcomes. Yes, but the history is we have 100 years of a campaign to try to reduce health disparities, and we haven't succeeded because we haven't changed these structures.
Yeah, and maybe can I add? I'll add one or two additional examples, but with the asterisk that Dr. Ramay just mentioned, which is that I think all of our efforts are incremental efforts. They don't address the root issue, which is what we really do need to address, because otherwise we're going to continue to have to make these different incremental efforts. But disparities in infant mortality are really important. Where in public health, one of the first things you learn in day one of any epidemiology course is that infant mortality rates are the canary in the coal mine, right? Where you see high infant mortality rates, whether it's within a racial group, a cultural group, a geographic group, you are likely to see other disparities. Disparities in infant mortality rates have persisted in Boston and in the US for decades. So to address disparities in infant mortality, looking at reducing rates of low birth weight births and premature births is the best way to do that. And one program called Centering Pregnancy took a group-based model to prenatal care to address disparities in prenatal care and to address these disparities in outcomes. And that wound up being a pretty effective model. At least it was 10 years ago when I looked at it. That might have changed since then. But this idea of having that group-based model where you're bringing people together, you're bringing women together and creating that sense of community and creating those social bonds, so that not only helps to improve rates of prenatal care, but it also creates those other social supports that are important and that can improve outcomes. So that's one model. The other model that has shown to be very effective is something called patient navigation. So where you have a patient navigator who helps individuals really sort of navigate the healthcare system, figure out how to connect to the services that they need. When I was at Brigham and Women's, we saw incredibly high rates of no-shows for colorectal cancer screening, so for colonoscopies. So these were in two primarily Spanish-speaking community health centers. We had some some patient panels where we had 100% no-show rates, and 60% of those patients needed a clinical, had a clinical diagnosis for a colonoscopy. So their healthcare provider saw something that was troubling, said, you need to go get this test, and people were not getting that test. So we tried to figure out, well, what's going on? So we did a whole qualitative survey. We asked patients, we asked their family members, we asked providers, what are some of the barriers, and got a sense of all the barriers. And then we hired a patient navigator from the community who was a Spanish-speaking patient navigator. In 1 year, this patient navigator brought the no-show rates from 74% all the way down to 14%. Our colonoscopy completion rates went from 40% to 75%. Those are extraordinary outcomes in 1 year. And it was entirely because of this one individual who was able to build that sense of trust with the patients and help them navigate the system. That was one thing, to address this. And that was like a little, there's one little dot in this universe of disparities. So we know that there's more to do, but there are models, but how do we scale that out? And how do we do that while also tackling these bigger issues that are continually, perpetuating these disparities?
Definitely, and thank you very much for those anecdotes. They're definitely useful in kind of seeing that there are some things being done, but it's not being implemented around the country, which they should be, since they are like smaller approaches that could be. Kind of going off of the different solutions that can be taken, given COVID and everything that we're seeing right now, digital health has come more into play. And ViTAL, as a healthcare innovation club, now more than ever, we're seeing that with stay-at-home orders, that digital innovations and just technology that's being available, they're happening at rapid rates, and they're becoming more prominently used in the healthcare field, and they're being used across a very wide area from low income to high income. So Dr. Gyan, would you like to start us off in kind of describing how effective can telehealth and telemedicine interventions be in reducing disparities?
Sure. I think when thinking about telemedicine or telehealth, it's important to, I think, yes, it has the potential to definitely provide services that are needed. But I think we also have to think of it kind of the context in which it's going to be delivered. And with any communication technology, I think it's important to think about the communication divide or the digital divide that exists. And with communication inequalities, there are differences among social groups in the way they access, seek, process, and use health information. And we know that communication inequalities, that it often mirrors the health disparities that we see here, such that people from lower social classes are less likely to take advantage and to use or even apply health information compared to those from higher social class. Dr. Maniar gave the perfect example of himself and his family trying to navigate the healthcare system with being as highly educated as they are. So, take that and think about that in terms of people who are from low income communities. They already are facing great barriers to accessing care in general. Yes, the number of people who do have access to, let's say, the internet or social media has increased, but there are still disparities that exist between those are high income and low income. So I think for telehealth or any telemedicine intervention to fully reach its potential, it has to first acknowledge those differences and the disparities that exist for communities of color. And particularly build in strategies to address those gaps that exist in whether people have actual access to the internet or to access those websites or the technologies in which the platforms in which these telehealth interventions are available. And not only that, but after accessing it, will they have the ability to comprehend or to apply it or to praise it and then apply it to their health decision making? So I think with any intervention, just a really clear assessment of the context in which it's supposed to be used and the population that's supposed to use it would determine its effectiveness, or whether it unintentionally can continue to exacerbate health disparities that already exist.
Sorry, I'm on mute. Just a quick comment, and I know time is going pretty much. I think you had an hour, so we probably need to move forward on this quickly. But a comment, just recently, I think just within a couple of weeks back, the very first video game was approved by the FDA to target ADHD. It's called EndeavorX. And obviously, the immediate question that comes to fore is what Dr. Jan was saying, which is with regard to access to this technology, or even access to digital tools, so that kids with this condition, and by the way, ADHD is reported or less diagnosed among African American populations, but also higher reports in observational studies. So access in the digital divide will obviously become a hindrance, to this new technology that has just been recently approved. It's actually a company based in Boston called Akili, which is a Swahili word for brain. Yeah, that was fascinating to learn about that.
Just to very quickly build upon that, because I think the importance of technology, and I often now, when I talk about social determinants of health, and thinking of social determinants of health as everything from housing, access to care, healthy and affordable nutrition, safety, all of those things that we need to be healthy. Technology has become a fundamental social determinant of health, and when we think about technology, so access to a stable internet connection, how many of us in the age of Zoom and Microsoft Teams are in sort of different meetings and our internet connection goes away, right? And but importantly, when we look at what's happening to kids right now, because everybody is homeschooling, and the schools that have essentially given up because they know that a large portion of their students don't have computers, don't have access to the internet. So they have no way to deliver education. And what that's going to do in terms of further exacerbating these existing disparities. When we think about telehealth, it's also a question of health literacy. And so how capable are individuals to, even if they have the internet, can they effectively use this platform? Are their providers able to have access to the resources needed to use the platform? And not just the physicians, but the other healthcare providers, the other allied health staff who will be interacting with patients in different ways. Do all of them have access to this resource to really be able to make the most of it? And how will this resource kind of further deepen and widen disparities, or will it help to close them? And I think it's become a very important issue for us to think about. So, we can provide the internet to everyone, but you sometimes need more than a cell phone to effectively engage in telehealth. And there are different levels of trust that individuals have with the healthcare system. So how does that play a role in this as well? And I think these are things that we're going to have to, more quickly than we would have, really think about, because telehealth is now here to stay, because unfortunately, COVID looks like it's here to stay as well for a while.
Thank you. I'm going to open up the floor for our open Q&A session from all of our audience members. If you have any questions, feel free to either put them in the chat if you're not comfortable with speaking them, or you can use the raise your hand functionality for it. So go ahead. If you have anything, just shout it out.
I have a quick question.
Sure.
For Dr. Maniar, the last thing you mentioned, trust. Could you kind of talk about that? Because that's one thing that hasn't been brought up that I've heard about, but I think there's definitely more to say about that.
Yeah, absolutely. We've talked a bit about systemic racism and the role that racism plays in the disparities that we see. Tied to that is the very justifiable distrust that communities have with healthcare systems, with large institutions in their community, large research institutions in their community, because of sort of the history of populations being taken advantage of. So that distrust can also impact the way in which, or the extent to which, communities or individuals will be willing to try something new that they may not be familiar with, or that they feel like, oh, if I engage in this telehealth visit, what's going to happen with my data? What is this hospital going to do? Are they just doing it because it helps them? And this is an important part of when we talk about doing community-based participatory research, when we talk about doing research in partnership with communities, the importance of building that trust. And I think trust plays a key role in having successful health outcomes. Trust between the patient, the provider, and sort of the patient's sort of support network is really important. Trust between the patient and the institution, the healthcare institution. But that can't be something that the institution feels is going to be automatic. It has to be earned. And in many communities, that's not easy, because the communities themselves have a lot of good reasons not to trust the institutions that are grounded in history. So that can impact the ways in which, when we think about telehealth, when we think about some of these new approaches to delivering healthcare, the extent to which communities will be able to fully access those new technologies. And I think it's important to talk about how this impacts clinical trials as well, and the fact that we already saw underrepresentation across many groups in clinical trials, and that's actually become amplified now. And so when we think about disparities and the way that COVID is impacting disparities, it cuts across many different domains.
Mm-hmm. Yeah, I could just add, I think that's one of the biggest issues or problems that there is. Consider, for example, this anti-science movement or anti-vax movement, and so obviously you can hear the messaging regarding, for example, wearing a mask. It has become so politicized in this country, particularly regarding COVID-19, and so. What if, when the vaccine is found, you have people who will just not want to take the vaccine, would refuse to take the vaccine, right? Yesterday, the WHO held for the first time a day conference on a new term, probably I think you may not have heard of this term, called infodemiology, which is this concept of infodemic in the context of COVID-19. There's just too much information out there. The anti-vaxxers are becoming more stronger today. In fact, they have a much broader connectivity in social media than people who support vaccines. So one study was published in Science a few weeks ago that predicted that in about 10 years, there'll be a greater sentiment towards anti-vaccine than there will be those voices supporting vaccines. Imagine the world we will be living in that time. Measles was eliminated in this country and then came back because you have people who are refusing to be immunized. So it's an extremely big deal.
Definitely, thank you. I see someone raise their hand. Jordana, if you'd like to ask your question.
Sure, thank you. Thank you all for your time. It's very interesting. I'll add one thing to Dr. Maniar. So my partner is a physician who works in a very underserved Hispanic area. And during COVID, they implemented telehealth, except they provided instructions in English. So if people could read, English was certainly not the language that they could read in. But, and it's a government-funded organization as well. But a question for all three of you. We talk a lot about disparities and what they are and the definitions, but do you ever, or how would all three of you define what success would look like, if that's even something anyone thinks about in eliminating disparities?
Go ahead, Dr. Maniar. I think
I can tell you what success would look like in my eyes. instead of talking about disparities during a webinar like this, when we have the chance to interact with all of you, we'd be talking about, how can we further improve health outcomes? Because we've already addressed the unfair, the avoidable, the preventable aspect of these outcomes. That's what success would look like for me.
Yeah, and I think absolutely, equal opportunity is not equal to everybody, but when we can have a scenario where life expectancy or health outcomes, since we're speaking about that specifically, are equal for all population, all groups, or we narrow that gap so much that it doesn't have other consequential effects. So that's what success would look like. But how do you get there? I think one point that was made, the journal Science, I normally read the publication on Thursdays. There was an article here, I'll just state a line. It's called Pandemics, Historical Role of Pandemics in Creating Inequality. And so this is a particular context in the US and the Navajo community, which we had the highest rate of COVID-19. How do you solve that? It requires changing the power relations to redress structural inequalities born by colonialism. So, I mean, so the application of the term colonialism in U.S. context is what you might not expect. But how are these communities then, like the Native Americans in this country, still remaining in sort of this sort of era of colonialism, where we need to tackle that? So if we can remove those kind of structural injustices and systems, then I think we can say, yeah, we're looking at success as well.
I agree with both of your comments, and I guess I would add that maybe the conversation would be more on health equity rather than health disparities. Because you have already created these conditions that would have allowed every person to pursue their most optimal health, regardless of their background, their race, their sexual orientation, their gender. So I think that was kind of the opposite, the other side of the coin for that.
Thank you, and thank you for your question. I see that the speakers have found the chat room and are answering some questions there. So if you're able to stay and answer those questions, that'd be great. I think because it's 7 p.m., I'm going to wrap up. So I just wanted to say thank you very, very much to our speakers for coming and giving us a lot of information and insight into the disparities that are present and just how we'd be able to help, even if it's just with our mindset and just being cognizant that these are things that are happening and that we can do our own personal research with the sources that Dr. Maniar has posted, as well as just a simple Google search sometimes. There's a lot of resources available. If you're on Instagram, especially recently, there have been a lot of posts that have been circulating, and there's always research articles that you'd be able to find. If you stay up to date with our club's Instagram posts and Facebook and LinkedIn posts, we have tried to share some things on this topic to the best of our ability and from our own research. And I'm very happy that we got to have this conversation tonight and that so many of you were able to join us. We will be posting a Medium article for a recap of this event. In addition, we have recorded it. So if you have friends or family that would like to watch, we'll be trying our best to post it as soon as possible. Also, please follow us on our social media accounts. We're at ViTAL Northeastern on Instagram. We're also on Facebook and LinkedIn. And we have our own website, which is northeastern.edu/vital. On there, we're going to be keeping up to date with our speaker events in the future. We have our fall pretty much planned out, even though we may be remote. We want to still kind of bring to light the different topics in healthcare and continue our core mission. With that, thank you again to everyone that's joined us tonight. And if you have any questions, feel free to reach out to us to get with the speakers.
Yeah, can I just add a comment? Since we are all faculty and we are all part of the scholarly community, here I always think that, and particularly to really commend you for organizing this event and for even taking a topic like this. There are tons of resources right now at Northeastern through the university, and take classes that can educate you, I mean, as a student. So I had a forum with other group of students that say, yeah, I mean, take courses in African American history. I mean, I learned about Juneteenth when I came to this country. I didn't know about that. And I called my mom and told her, you know, today is Juneteenth. What is that? My mother lives in a village. She fought the independence war in Kenya, but I had to explain what that means. It's a momentous date. And I teach a course in pandemics in the African diaspora. So take courses like those that will educate you more, so that you can understand these histories that we are talking about. And courses that really become enriching, and obviously commend you to continue to be engaged to work towards a society that is just and equal for all.
Thank you.
I'd like to just echo all of that and thank you all so much for organizing this and for inviting us and for participating and for the very engaged questions and discussion. I feel really hopeful by the fact that, you know, all of you at this point in your own educational and professional careers are taking on this issue, and keep doing that. Keep learning and keep educating others and keep pushing the conversation.
Thank you. We'll try.
Right, and I echo the sentiments of my colleagues here, and I think I would leave you with 3 things to think about that I often try to kind of keep as a guiding light, in a sense, in the work that I do. And it's from Kamara Jones, who is the former president of the American Public Health Association. And she does a lot of work on health equity, but she provided 3 underlying principles that if we practice, we can get us closer to health equity. And the first is to believe in the fact that we should provide resources according to need. The second is to value all individuals and populations equally. And the third is to recognize and rectify historical injustices. And many of you are in different fields and future leaders of this world. And I think if you keep those three principles kind of as your guiding light, or as how you shape your worldview, I think whatever field that you engage in, it'll be much better because of that.
Thank you for that summary. I think it perfectly summarized kind of everything we were going for tonight. So thank you everyone again for attending, and for our wonderful speakers. I hope you all have a great night and a great rest of your summer. And I hope you keep the topic we discussed in mind as you move forward.
Great. Thank you, everyone.
Thank you all.
Thank you.
Have a good night.
Bye.